and has really does both things. He's received multiple teaching awards, as well as I noticed that you received the Distinguished Faculty Award for Patient Care last year. And that's, of course, how I got to know him, through education and taking care of patients. More formally, he did his undergrad work at Wake Forest, then Eastern Carolina University. Before he did his PhD, he worked at Duke University for 3 years in their outpatient clinic, and then got his PhD at Florida State University. So we've become an ACC guy, and you've been an ACC guy all along. In fact, he told me last night the first time he visited Louisville was to see the Final Four in 62. He was 12 years old, if you want to do the math. But a special kind of memory in him. He's black, and we're glad to have him back. A couple of things. It's really, to say you can learn something from a friend, I mean, it always humbles you. And it took me a long time to admit that he was teaching a lot to me. So I got interested in family work and kind of the esoteric things about family systems, and the idea that there's a family arguing, and during the session the kid has an asthmatic attack, and when the parents go to look at the kid to take care of him, all of a sudden they stop arguing, and then maybe his symptoms were to get him to stop arguing. But Alex taught me, sometimes you just need to teach parents what to do. And the parent management training and his work as teaching, we still actually use in our own program today, Chris. And through numerous national presentations and things, I just enjoyed working with him around parents. So he asked me about a talk. He said, I've got something I could really do on ADHD. By the way, has anyone heard of ADHD? I said, well, that would be fine. Be one of probably the 40th one yours would have been better. But so he said, and he gave me a list of things. What about the angry child? I said, that's it. Children who are dysregulated, who are rageful, who bust things up when they don't get their way, and they do it in your offices and in our clinics. So that's the topic today, and Alex is going to come and speak on understanding and treating child anger. Thanks for coming to Louisville, Alex. Let's welcome Alex.
Thank you. It's a pleasure to be here, and always enjoy connecting with Alan, so that's very good. So I'm going to go ahead and jump right in to the topic. I want to make sure I have time to not only give a presentation, but also to invite questions or discussion as we go forward here. I hope that you'll find this relevant, even if you're a neonatologist, because you will deal with anger. I can promise you that in your practice. So I have absolutely no disclosures. I've been trying to get some, but I don't have any, or any conflicts of interest. All right, I have a very simple objective here, which is to help you understand anger in the context of child, of course. But then, of course, to translate that into practical responses. How can you handle a child who's having anger issues? And for those of you who are in the psychiatry business, to how to engage in an effective treatment approach for children who have persistent anger problems. Children need love, especially when they do not deserve it. That's a very powerful statement and a very true one, and one that requires that we think about how we respond to our children, even in the context of their sometimes outrageous behavior. So let me see if I can get this to work.
Me? Action. I don't like people looking at me like that.
Like what?
Stop it!
I don't know how else to look.
You're a stuttering Stanley!
Excuse me?
You talk funny when you went to school here. You talk funny all the way to high school.
What?
You shouldn't laugh at people. It makes them feel bad.
How did you?
Stop looking at me!
Who have you been speaking to?
Stuttering Stanley! You're a stuttering Stanley!
Who?
Stuttering Stanley!
Stop it!
Stuttering Stanley! Stuttering Stanley!
Stop it!
Stuttering Stanley!
Shut up!
Lovely, huh? So how did you experience that video? What did you notice about your own reactions? How many of you went, yep, been there, done that, seen that? Okay. How many of you had a sense of tension growing as you observed that experience? Yeah. How many of you wanted to take that little kid over your knee? How many of you wanted to say, shut up? So notice our natural responses to these kinds of children who engage in these outrageous behaviors. All right, let's see if I can get back to the... So today, of course, I'm trying to address specifically this kind of kid. How can we help him? How can we understand him? What are the kinds of ways of responding? The developmental course of anger problems is very well studied, actually. By the way, I became interested in the area of anger in children because when my daughter was about 2, I think, maybe 2.5, put her in the daycare for just a few hours each day. And for the very first time, she goes, the very first day, I'm in graduate school, take her to daycare, and she has a major temper tantrum at the school, busts the steel reinforced glass in their door. So I get a note from her daycare saying, we think your daughter has problems and needs to see a psychologist. So I thought, well, I need to understand this better. So she's fine, by the way. She's all grown now and has her own daughters. So what do we know about temper tantrums? Study of temper tantrums is quite interesting because, one, it's kind of a pure form of anger, and it teaches us a lot about what the nature of anger is just by observing temper tantrums. And we see that some children have a very high rate of temper tantrums, anywhere from 5 to 9 temper tantrums a week and even more. For the really irritable kid, by the time they reach 2 or 3 years of age, they've had 500 temper tantrums. I mean, that's almost as much as the chairman has on a yearly basis. I mean, was that the chair? No. And what's the implication of that? That means they've had a significant rehearsal of this anger experience. And as we know, in a kindling effect, the more you have it, the more you have it. And so, as we see, these children who have these multiple temper tantrums, as they become older, it becomes very stabilized in their response to frustration. So increasingly, they are more likely to have these episodes. Not so much formal temper tantrums, screaming fits, but angry reactions to situations. And unfortunately, that trajectory continues on into the adolescent years and even into the adult years. So it's a very predictable but problematic history that will come for these kids who early on demonstrate these irritabilities. It is probably the most common reason for referral. More so than mood disturbances as in anxiety or depression, behavioral disturbances are often associated with anger issues. But looking, of course, you got to keep in mind this is New York, so I don't know. There are angry people anyway. I'm from the South. That was a joke, okay? But look at that. Almost half of the referrals involve some aspects of anger. What is the impact of this irritability on children? Well, it's dramatically problematic. It's associated with aggression and externalizing behavior. We'll talk more about that. It's not always the case, but it can often be. But it's also associated with development of depression, anxiety, suicidality. I mean, if you're chronically irritable or chronically having conflict with others, you can imagine the impact that's going to have on your life. Eventually, it's going to have a very disruptive effect on relationships, both in the family as well as with peers. Often there is school problems that are associated with this problem. Increasing health problems. If those of you who are pediatricians, hopefully you understand that a good percentage of the kids who are chronically ill, there's an influence of behavioral health that's going on there. That there are chronically stresses that are part of the picture. I did a study a few years ago looking at hospitalization, pediatric hospitalization. One of the things I discovered was that a high percentage of these kids had family stresses that preceded the onset of the acute illness that resulted in hospitalization. It's not random. There are important health relationships with irritability and anger expression, and development of substance abuse problems in adolescent years. So, often I think in insurance businesses in particular, they kind of put an emphasis on internalizing disorders, the depression, the anxiety, the bipolar, the kind of typical things we think of in the psychiatry world. And yet it's the externalizing behavior problems, it's the acting out behavior problems that probably have even a greater impact on children. So we need to take it seriously. Unfortunately, society's kind of taken the point of view, well, they're just misbehaving kids. They need, just some good discipline, and that's all it's going to take. Well, hopefully you'll see today it's going to take more than that to deal with these children. What are some of the common diagnoses that are associated with this kind of global symptom of anger, irritability? Right at the top of the list is oppositional defiant disorder. These kids are hardwired early in life to be kind of irritable, to have a low frustration tolerance, to be defiant and strong-willed in their temperaments. And so it's not surprising that a lot of the kids who come in with anger, irritability problems are also will be given a diagnosis of oppositional defiant disorder. Attention deficit disorder. I'll say this probably again, but I think there's some common neuropathway problems for children who have attention deficit and kids who have irritable and problems with anger regulation. There's some important inhibitory processes that just aren't working very well that are influencing children. Anxiety disorders. We wouldn't necessarily think of anxiety and anger going hand in hand, but in fact they do. It may have something to do with insecure attachment early in life. So they feel this general sense of threat and uneasiness that kind of drives their anger. Depression. And just as a point of major emphasis, notice what's right at the bottom, like the least likely thing to be present, bipolar disorder. Bipolar disorder actually is a very uncommon condition in children. There was a kind of a wave of popularity using that diagnosis, but I just caution all of us that the reality is, and when you look at really clear criteria for bipolar disorder, very, very few kids that you'll see in your office, so whether it's pediatric or psychiatry, will actually have that diagnosis. There's a new diagnosis in DSM-5, disruptive mood dysregulation disorder. It's a really compelling, interesting diagnosis. However, we know very little about whether or not it's a true syndrome that actually fits together. We can see the general prevalence may be, possibly be around 8% of the population, but very, very high comorbidity. So it's not clear that it's a readily discriminated diagnosis from children who have other conditions. But it does specifically address the anger, irritabilities, temper tantrums. And so in that sense, from looking at children with anger, it is an interesting diagnosis. But we know so very little about its prevalence and its construct validity, quite frankly. So let's begin to look at the anatomy of what anger is. And let me start by just talking about emotions for just a bit here. Emotions are these action tendencies that we have that are rapid, that involve physical changes, a state of arousal often in the case of anger, but also subjective feelings, a shift in what you're focusing on, your attention, the ways you're thinking about the situation are all kind of early programmed responses to various situations. Now let's imagine this scenario. Let's say you go to New York and you have this wonderful day touring the city, you have a nice dinner, you go to a Broadway play, and you're just imagining all of these things you're going to do the next day. So in this point of time, your emotions are very positive. And when you have these positive emotions, it opens up your thinking, you're very flexible, you have a sense of comfort and ease about yourself. And so these positive emotions have a very kind of a flourishing effect on our lives. So you're walking down the streets, heading back to the hotel, and you turn the corner, and the alley's rather dark, and there's a group of young men, let's say, which you are unfamiliar to you, and who are kind of walking in irregular ways, and they're heading towards you. Now think about what you would experience. Well, first of all, your thoughts of what you're going to do tomorrow are no longer there. You're not thinking about what you're going to do tomorrow. Your range of focus is now completely focused on this group of men heading towards you. And your physiological state is now revving up to either run or fight. Okay? And so your whole world becomes very narrowed and very focused, because what is at stake for you now is survival. Okay? So notice the contrasting emotions. The positive emotions tend to open us up, to make us feel at ease. We are creative, we're flexible, we're able to think of all kinds of things. But when the negative emotions hit, what's going on is we are mounting a response. We're getting ready to respond to what seems to be a survival mode for us. Now, negative emotions can also be a representation of how important an event is. So when you have extreme grief, for example, it kind of is a marker for how important this event is in your life. All right, so that's just a quick overview of emotions. I didn't nearly do justice to it, but it kind of says that emotions are very powerful, important parts of our lives, and they have contributions in both sides of this, both positive and negative, can be very positively influential to us. The negative emotions, again, mount us for survival, and sometimes that's great. Sometimes that doesn't work so well. Sometimes it really is not a survival mode, and yet we treat it as if it is. So I'm going to, don't worry about reading the small print here. I'm going to go through each section. But just to say, the anatomy of anger is about looking at physical response, what's going on physically with this individual, what are the thought processes, which turn out to be quite amazingly complicated in terms of understanding children with anger, and, of course, the action tendencies. How do we typically respond to anger-provoking situations? So I'm going to focus primarily on looking at the child who has anger problems, and you'll see that kind of bent here. I will not be necessarily speaking to just general normative experience with anger, although I'll kind of blend that a bit. So the child who has anger problems has a high sensitivity to signal. I mean, this is an oversimplification, but it's kind of like they see more, they hear more, they feel more. It's just like the world comes at them and there's no filter in it. And so it just kind of hits them hard. And so things are tougher to deal with. They increase their stress in a much more rapid rate. They also respond in a kind of a disinhibited way. So in other words, they lack those regulatory processes in the prefrontal cortex that kind of slow things down and bring it into some kind of regulatory state. But instead, it's a quick flash of uninhibited response. And so their levels of arousal are high. Likewise, they have difficulty down-regulating that, so it takes a long time for them to recover from it. And this is really important, they get there really fast. Really fast. When I teach parents about how to deal with children who have anger problems, I essentially say, once it starts, you have about 1 minute to decide what to do. Because within 1 minute, their brains are gone. And I really mean gone. I say it like this. So, if your child has reached that hot reactor meltdown, that where I've got it circled there, if they reach that, it doesn't matter what you say to them, because they're going to go through this storm regardless. So you could say, if you don't stop right now and calm down, I'm going to hit you with a baseball bat. It wouldn't matter. It would not matter. Or you could say to them, if you will stop right now, we'll be heading to Disney World tonight. It wouldn't matter. Their brains don't work. And so it's very important to understand this physiological rapid response in order to be effective in dealing with children who have anger problems. Again, the neurobiology, as always with human function, is very complicated. We know the prefrontal cortex has something to do with the regulatory system, but there are probably other networks of systems that come into play. Very similar, I might add, when you look at the neuroimaging and the functional neuroimaging studies, very similar to what ADHD children look like. Very similar dysregulation problems in their brain function. All right, what about their thought processes? What does that look like? Well, thought is very important. How you interpret what's going on in your life has a significant role in how you're going to respond to it. So the most common trigger for anger is being blocked from a goal. Not being able to get that important goal attainment that you hope to achieve. But there's also can be a sense of threat, either pain, fear, confinement, or also important trigger events. Usually not physical, but can be, but often is more psychological threats, feelings of being humiliated or put down. So you can imagine if you're 12 years old and you're walking down the hall and you're carrying your books and some kid is, not paying attention, running through the hall, rams into you, knocks your books flying everywhere, and all of your friends and all the kids around you are laughing at you. What would you think? How would you react? Well, again, it has significant way of thinking about this situation. So some kids might just laugh and say, "That idiot, what is he doing?" and laughs along with everyone else. And on the other hand, the other kid does not react that way. This becomes an infuriating challenge, threat to them that they have to deal with. So the kid who has irritability and anger problems often have a high perception of threat. And there may be important developmental experiences that influence that. I'll talk about that later. But the reality is they are quick to see danger. They're quick to interpret this as being blocked from a goal. They also have trouble interpreting faces. So I could look out in the room right now and say, "Well, some of you look angry at me. Why are you looking at me that way?" This is the kid who raises his hand in class and said, Teacher, he's looking at me." And the teacher's going, "What? What do you mean he's looking at you?" And you look at the kid and he doesn't look like he's doing anything. Well, it turns out that children who have anger problems have difficulty reading faces. I mean, you get pictures of various states of emotional feelings and ask a child who has anger problems, what's going on there? What is their face telling you? And they just have a great deal of difficulty. Now, there's another kind of kid who has similar kind of problems. Can you guess what other kind of child has problems reading faces? Autism spectrum disorder kids. So guess what? They are prone to anger problems, in part because they just have trouble reading faces. And by the way, for survival reasons, if you're not sure what the other person's thinking, it's probably safer just to assume that there's evil, bad intent. It's safer to do that. So when you're not sure, it's often going to be the case that you will lean toward a negative interpretation of what's going on. And children who have anger problems will have difficulty in both ambiguous situations where it's kind of neutral, it's hard to figure out, but even in unambiguous situations, even when there's absolutely, from our point of view, very little evidence that something's going on here, they will interpret it as a hostile, potentially problematic situation. What do they tend to believe then? If that's how you see the world, how do you start thinking about other people? There's significant research looking at how the children who have anger problems have a very strong hostility bias. They really think people are against them. And in practice, I see this all the time with children who have anger problems. They're constantly interpreting every little situation as evidence that there was hostile intent behind the action that was taken. And even with me, I'm just a really friendly guy, and they'll think that I'm being hostile to them. I go, I was working with a kid who clearly does have autism, and I was asking, I was kind of making a point, and I said, I forgot exactly where I was using. I said, something like, "Well, do you use your logical mind?" And I said, "Do you know what logical means?" I mean, it was just a simple question, and he goes, "What do you think, I'm stupid or something?" He saw that as a hostile question. He interpreted it that way. And again, with anger kids, that's very common. Implicit theory is an interesting field of study looking at how people theorize the way people are. And the research shows that a high percentage of us think that people are fixed. They just are what they are. And they will say that about themselves. Well, that's just the way I am. Like, people don't change. And it turns out that children who have anger problems very commonly think that way. People don't change. I don't change. you don't change. So if you have no ability to affect the other person in a positive way, what's going to be your primary go-to response to that person? To dominate them, to control them, because they have to be controlled, because they're not going to change. I will not have any ability to influence them. And so that implicit theory, that fixed way of thinking about people becomes a problem. Children who have anger problem have a strong sense of needing to be dominant, needing to be in control. Again, this has in part to do with their insecurity, their sense of the world is a hostile place. And if you think that if you feel insecure and you interpret the world as a hostile place, it's very important to be in the dominant position, in control of the situation. And I like to explain this to parents. I said, the child who's like this, it's not as if they are wanting to be rebellious or wanting to be difficult. That's not their real motive. Their motive is they don't feel secure unless they're in control. So it's not just defiance. It's really about, I have to be in control because of their sense of the world. Perceived injustice. It's not fair. There are two very important components of anger. One is they're always the perpetrator. Always. There's always someone to blame. Which is funny, when we have that lawnmower and we can't get it started. We get angry at the lawnmower, like, you're doing this to me. We personalize it. And that's the nature of anger. Always a perpetrator and always a sense of injustice. It's not fair. Attentional control. They can't take their eyes off of it. Very inflexible in their focus. Very inflexible in their response, ability to reverse, to change, to adapt to the situation. They are driven toward dominance and control. They can't stop thinking about the insult. These are the kids who will seethe with anger for a week or more about some insult, some minor insult that occurred, and will eventually will want to retaliate. And you get a jury of their peers and going, what are you doing? Just let it go. Stop thinking about it. They have a hard time doing that. It's very hard. Again, I think it has to do with that regulatory system, where there's lack of flexibility in thinking, adaptive down-regulation of their anger. They have a hard time doing that. And so you keep in mind what I said about anger. It is a highly focused experience. Everything else is wiped out. You don't think about anything else. You're not adaptive. You're thinking survival. And when you're in that mode, it's very hard to be able to be flexible and reverse your responses. All right, action tendencies. Now, whether or not we express our anger in aggressive ways is very much socialized. We learn how and when to express our anger. And so we will have the degree of threat involved, like how dangerous, how bad is this, will influence our response. We will do a power differential. We will determine, okay, I just got pulled over by the police officer. He's walking up, with his pad, and I'm really late and I'm really frustrated. Am I going to express my frustration to the officer? Well, hopefully you don't. It will not go well for you because you did a power differential. Like, I'm in an out of position to think this. If I'm really thinking about this, I am in no position to argue with the police officer. Okay. Now I must confess that when I was in the 5th grade, we were playing a softball game, and the principal was supposed to be the catcher for both teams, and we had student umpires. Okay. Now, in those days, I was a very competitive athlete. I just hated to lose, and we were playing this game, and it was very close, and I hit the ball, and I ran to first base, and my teammate ran from second to third, slid into third, and the student umpire said, safe. The principal, who's supposed to be catcher for both teams, walked over and said to the umpire, no, son, he was out. To which I said, no! You shut up! Now, that was not a good power differential interpretation. That was not what I should be doing. And I got in a lot of trouble for that impulsive response to that situation. Now, I say that because children who have anger problems often are very flawed in their power assessment. They simply don't think about the consequences of taking on the principal and telling the principal to shut up. Because they are so hyper-focused on the hostility, so hyper-focused on being blocked from the goal, they don't think about the consequences of acting in an aggressive, in my case, a very disrespectful way. We also know the degree of relationship, how strong the relationship is. If you care a lot about this person, you will have a greater sense of inhibiting an aggressive response. Unfortunately, children who have anger problems often have a low relationship strength. They have not had good experiences in relationships. Often they've been problematic. And so they have I don't care. I don't care if you don't like me. Nobody else likes me kind of attitude. And so their strength is inadequate to handle the situation. There are, of course, what kind of response options do you have? I mean, what else could you do? I mean, quite frankly, I did, back in the 90s, I did a research project looking at anger in children, a fairly large study, about 200 subjects, I think, in the study. And, we discovered that the pretty basic finding was if another student comes up and slaps you in the face, there's really only one other option. There is no other option. That's to slap them back. I mean, that's it. So it's depending on what the situation is. You may not perceive. Obviously, you do have more options. But when it's that strong and it's that much of a threat and that kind of an affront to you, then you've got to fight back. Now, of course, that also reflects how skillful is the child. The less skillful they are, the less in their repertoire of responses, the more likely they're expressed in an aggressive or problematic way. And then I've already mentioned it, but the degree of impulsivity strongly influences. The reality is most of the time, most of us do not act out in an aggressive way. We do a variety of other things. We will hold it in. We will try to suppress, use distraction. We will shift away from the stressor, try to stop thinking about it. We'll do problem focus. There are a lot of other options that are available to us. How accessible are those to the children who have anger problems? Not so much. All right, there are common developmental influences. There are families that are just grumpy and irritable. I don't know if you remember the Far Side cartoons, but one of my ones I liked had 3 pictures, and it said someone holding a glass half empty, and the one was saying, "Oh, this is great. I got a half a glass of water," and the other one says, "My glass is half empty," and the third one says, "Damn it, I wanted a cheeseburger." And that's the family. That's the family that just has this incredible irritability, and of course it's an interactive process, so they're irritable, so engage in problematic behaviors, and it creates irritability among the whole family. Children, we've already started introducing the idea of temperament. These children have anger problems, they're irritable, they have low disposition toward relationships, they don't recognize and understand emotions very well, they tend to perseverate on threats or challenges, and they really don't have private speech. Most of us have a little internal speech, so that when I'm in my office and my chair comes in and says, "I need for you to do this, I need it tomorrow," and I'm really busy, and I'm going, I don't want to do this, but I have a little internal language that says, you probably need to do this. Turns out that children who have anger problems don't have that internalized language. Exposure. It's not just biology. It's also what happens to you. And so if you've been through life experiences when there's been provocative, there's been a lot of anger expression in your family, there's been even trauma, there's been parental conflict, I'll talk about that in a second. In other words, they're observing, socialized to engage in these anger expressions that are problematic. They're often rejected by peers. And again, this attributional style. Parents. It's always the parents' fault, right? No, it's not. It's interactive. See, if a grumpy, irritable kid, they're going to be a very challenging child. And they're often going to push you. They're often going to push your buttons. And of course, that has a very challenging context for the parent. But there are some very important parenting features. One is a lack of secure attachment. The parent is not engaged that child in nurturing ways while also providing clear rules, clear consequences. If they haven't established that pattern, then the child has a fundamental insecurity about life. Exploring the world is hard for them. They often feel a sense that they're not competent to manage the situation. And that creates a vulnerability that often can lead to anger problems. Parental displays of anger, not just to the child, but we know that families where there's high degree of marital conflict, when there's a lot of screaming, yelling going on, we know that that produces a feeling of insecurity on the part of the child, and the child is learning, modeling after parents' inappropriate expression of anger. Parents who are highly coercive, withholding, what's called sometimes the authoritarian parent, who's high on discipline but low on nurture. These often produce children who become very frustrated, very challenged in their social relationships. But likewise, on the other end of that spectrum is the indulgent parent, who pretty much the world revolves around them. Now, why would that produce an angry child, having an indulgent parenting style? Well, they pretty much give the child whatever they want. Why would that be a problem? Why would that cause frustration and anger? One, they don't develop competence. Number two, their sense of justice, what's fair, is completely distorted. They come out of that experience essentially saying the world should revolve around me. And if it doesn't, I'm infuriated by this. This is unacceptable. This is not fair. And of course, they do horrible in the school or other social environments outside of the home. And even in the home, they begin to become little tyrants. Why? Because their sense of how things are supposed to be is so incredibly distorted. And they are not learning competencies that will help them adapt. Just a quick note, and I'm going to rush through these slides very quickly, is to say that anger is not equivalent to aggression. Not the same. In fact, in the research that I did, the highest correlation with other constructs related to this whole phenomena was not aggression with anger. Kids high in anger were not necessarily higher in aggression, although I think there is some to the degree of that. But the highest correlation was with depression. It really does have a mood impact on the child that's quite pervasive. So anyway, just to say that when you look at aggression, on the other hand, there are certain types that we can pay attention to. Some are early onset aggression. These kids develop very aggressive behaviors early on, and unfortunately it has a very poor prognosis. In other words, they're establishing themselves as a pattern of life of aggressing and toward others, and it's really hard to work through that. On the other hand, we have some who are pretty good kids until adolescence, and then they become rebellious and they engage in aggressive behavior. But that's not quite as severe, and the prognosis is a bit better. We know that some have an overt pathway where they're demonstrating very outward expressions of aggression. They're bullying, annoying, causing fighting. On the other hand, some are very covert. They're sneaky. They damage property without people knowing about it. And then the other class of, or trajectory rather, is the adolescent who begins to just be rebellious around the early or adolescent years. The point I want to make here is that for the angry child, the pathway tends to be more relational in nature. It's more about conflict. They aren't necessarily naturally angry. They don't try to be using their aggression to get instrumental outcomes. That's not how they're functioning. They're rather acting out their aggression because of the irritability, because of the distress they're experiencing. That's a very different kid than the criminal who spends a lifetime stealing, beating people up to get what they want. So I want to just make that clear distinction. All right, so we'll finish up here then with thinking about treatment. And I'm going to do this in a twofold manner. One, I'm going to start with kind of the research, looking at what do we know about how to treat anger, and from a clinical management perspective. And then I'm going to finish up with more practical how-tos. Like if you're a parent or if you're a physician working with a child who's having an anger episode, how can you best handle that situation? So let's start with the pharmacological treatment of children with anger, and the evidence is very, very, very weak. The fact of the matter is there are very few randomized controlled trials looking at how to deal with anger. And the trials that have been done in a very formal, very precise way, the outcome is very, very equivocal. So when I have this list of promising, tentative, I really should underline like 3 times tentative, because these are mostly open trial studies. They're really expert opinion conclusions, and there's very little science, quite frankly, that's at this point in time able to give us a clear pathway to how to manage. Now, there are some children who have attention deficit disorder, and a lot of the anger expression is because of their impulsivity. And there's some positive suggestion that treating the attention deficit impulsivity with medication can be helpful. But I can just say that as a general conclusion, this is fairly recent review of the literature, by the way, pretty disappointing results, quite frankly. There's just a lot we don't understand of how to treat the biology of the child with anger. What about psychotherapy? Let me start with saying venting does not work. Do not buy your child a Bobo doll they can beat up when they're angry. Do not encourage them to scream and beat on their pillows. Any kind of outward aggressive expression of anger promotes more outward expression of anger. Okay? So just wipe that off your tablet of things to do to help a child who anger. Getting them to express their anger in a very outward, expressive, aggressive way is not effective, and the research is quite clear that it makes it worse. Okay, so don't do that. On the other hand, there are some important interventions that seem to be promising. Again, if you look at the effect sizes, those are either fairly modest to maybe slightly decent effect sizes. Again, it kind of just says it's a field that there's a lot we need to learn about how to help children with anger. But we know that helping parents to better respond to this is probably one of the most important things we can do. And there are some specific cognitive therapies, which I'm going to now elaborate on, that also can be helpful. So let's talk about the parents. We've got to break up these patterns, these angry outbursts of patterns. I just was working with actually a pediatrician the other day who has an adopted child, and she was describing how they were having homework battles. I don't know if you've ever had that experience, but this is a lot of fun. And she described how they were getting increasingly angry with each other, and finally they were just screaming at each other, and then she finally got the child to do what she wanted. Now, what do you think is the long-term impact of that? So one, the parent just got reinforced of screaming. And number two, what did the child learn from the parent? That when you're frustrated, things aren't going your way, scream. Okay? And so, obviously, that was a point of intervention. I've got to get the mom to stop screaming. Now, that's easier said than done when a child's incredibly frustrating and pushing your buttons. But learning how to engage with the child in more effective ways, learning to de-escalate things, not to escalate things, but also to increase their positive interactions. Remember, we talked about the importance of the attachment, security. I've got to have a developing, building, maintaining relationship between the parent and the child. Because I believe that as the child who has anger problems has increased confidence that their parent believes in them and is there for them, I think the threat of life becomes less and less for them, and they're much more manageable. We also want to improve their emotional communications. I want them to be able to talk about things that are frustrating, but not screaming. So learning how to have conversation. Ross Green has a collaborative problem-solving approach, which is wonderful and very effective in helping parents learn to engage with their children in more appropriate ways. What about the child's points of this? Well, one, we have to work on this way of thinking about themselves. It's called incremental theory. as opposed to implicit theory. It's basically saying, look, people can change. It's hard. It's going to take work, but you can change. You do not always have to be that person. I have a young man named, his name is Thomas. He's had a horrendous 2 years of major temper tantrums. I mean, throwing knives, getting on the balcony, threatening to jump off in a fit of anger, threatening to beat up the used car sales. I don't know where that came from. Just horrible, 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 horrible. And he has this incredible pessimism that this is who I am. This is the way my life is going to be. And you can imagine how hopeless he feels. And the fact is, he gets reinforced for that hopelessness on a regular basis. He has a temper tantrum. Things blow up. He's been admitted in the hospital several times. He even went into an extended care hospital for a while. Just horrendous. Well, the good news, still a work in progress, is we have put him in a residential school, therapeutic school, and it's in a wilderness type program. And if he throws a temper tantrum, he can go out in the woods and and do whatever he wants. But until he pulls himself together, he's not going to have a decent place to sleep, and his food is not going to be that great. And so he's learning to kind of hold it in and pull himself together, rather. And so he came home. I see him about every 5 or 6 weeks when he's on leave from the school. And he came home and he was telling me what he was learning and how he was learning to control his anger. And he had this wonderful thing he said to me. He says, I'm not allowed to talk to my parents on the phone, but I write them letters. I went, wow, that's cool. Very, very upbeat. And then as I was walking out with the parents, I said, I understand he's sending you letters now. And they were, yeah, it's incredible. And you know how he signs his letters? No, what? Well, this family has 5 children. The youngest had some birth trauma and was kind of a PICU baby who had some trouble, but survived and is doing great. They call her the miracle child. So that's the setup. And so they said, Thomas wrote this letter, and at the bottom he signed, "Your second miracle child." A glimmer of hope. People can change. Very important for a child who has irritability, anger, to give them that hope. Increasing emotional awareness. Being able to read faces. Being able to read their own emotions. If you don't know you're about to blow up, if you don't recognize it, it's hard to manage your response to that increasing feelings of stress. And so teaching them how to do that. Recognizing the anger, learning ways of expressing it more effectively. Got to deal directly with a hostility bias. Really some basic cognitive work around what you think, how you're interpreting situations, what are alternative explanations. Improving their flexibility in problem solving. Angry children have one way things are supposed to be. And if it doesn't happen that way, they're enraged. So they need to learn there's more than one way to fix a problem. That problem-solving skill is very important. And then last but not least is developing better social skills, more flexibility, and of course heavy modeling to help them to learn those things. All right, so let me finish up. I think I'm on track here because I wanted to leave time for discussion. I hope I've provoked you to have questions and discussion. What can you do in an anger crisis? The first thing, the most important thing, which I must say that is the most common error that adults make, is don't throw gasoline on the fire. So the child's having a temper tantrum, saying things like, I hate you, I'm going to kill you, and blank, 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 blank. Fuming anger. How effective do you think it is if an adult says, if you don't stop that right now, you're grounded for life? How effective do you think that's going to be? Not only is it not effective, but it just throws gasoline on the fire. So making threats in the midst of an angry storm is likely to produce no good outcomes whatsoever. I would add to that, number 2, orchestrate a timely removal from the provocation. Remember I said when children are angry, they are hyper-focused on the perpetrator, They're only thinking about what they're going to do to the perpetrator. They can't think about anything else. Is this a good time to talk? It is not. Because remember I said they can't think. So if you try to have a conversation in the context of an angry storm, you're going to make it worse. And so what they need is a lot of time and space. I see this so often. I get calls from parents saying, my child had a blow up at school and they got in a fight, and I'm going, what happened? Well, what happened was they were angry and they were misbehaving, no doubt about it. And what did the teacher or the administrator do? They moved in. They got close. It's like cornering a tiger. You don't want to do that. You want to get space, time. We'll deal with it later. We're not going to make threats. We're not going to discipline you. We're going to give you space and time. Very important to do that. So I like to use the expression, strike while the iron is cool. So when things are cooled down, then it is appropriate to have a conversation. You want to have a conversation. And how do you start that conversation? Well, let me tell you, man, we're not going to put it... No, that is not the way to start this conversation. That is not the way to start this conversation. Is that clock right? I have no idea what time it is. I just realized I've been looking at it like 5 times and it hasn't moved. All right, so all right, so let me move along. So we have to start with empathy. We have to start with understanding their point of view. Our goal is to teach them to use words and for us to listen. That is the start point. And get the problem away from who the problem is. Who the problem is, get to the what of the problem. As long as they're focused on who, according to the research, including mine, the only thing they care about is getting rid of or at least hurting the perpetrator. So we've got to stop talking about the perpetrator. Keep it short and sweet when you're giving their point of view. They need to hear your point of view. Establish that it's a we problem. Too often we shoot up ideas of how to fix their problem. They shoot it down because they can't interpret that as it's not my problem, it's your problem. You're having to fix it, so give me ideas and I'll tell you they're wrong. Not going to work. Instead, we want to work on collaborative approaches. Let's work together to figure out how to solve this. Helping our children with anger. I love this little story. As a teacher asked the students, what do they want to be in life? And they got the traditional answers. I want to be a lawyer. I want to be a doctor. I want to be a teacher, et cetera, a fireman, so on. Everyone answered except Tommy. Tommy didn't answer. And then finally the teacher realized it and said, Tommy, you didn't answer. What do you want to be when you grow up? He said, I want to be a possible. A possible? What do you mean? Well, my mom is always telling me that I'm impossible. So one day, I want to be a possible. It's kind of cute, but it's all kind of sad too, isn't it? Every child in this world wants to be a possible. Even the angry ones. It's our job to give them that vision that they are a possible. Okay, that's my remarks, and I'll open it up for any questions or discussion.
I really enjoyed your talk, and I found it very helpful. Couple questions, I guess. One, have there been any studies looking at how you identify these children at a very young age, maybe by temperament or whatever? And I would think that would be very helpful to avoid some of these dysfunctional patterns developing in the first place. And then you mentioned a significant number with comorbid anxiety disorders.
Yes.
Have they looked at use of SSRIs or other medications to help with that part of the population?
Yeah. Great questions. One, I love the first question because it gives me opportunity to say, guess who has to do this? Guess who has to identify these children early in life? The pediatrician. Yes. I think that's part of your task is to help. You're absolutely right. I mean, theoretically, is still a study to be done. But I think early identification, keep in mind that they develop these anger patterns early and become very repetitive. By the time they're 3, they've had 500 temper tantrums. So early identification of these irritable kids and addressing that early on with parenting efforts and other resources. But I think really the pediatrician is in the ideal position to ask about temperament and ask about how they're handling the terrible twos and how that's going. I mean, a lot of kids too will have these temper tantrums, but it's the frequency and the severity of them that are very, very important. The second question was having to do with SSRIs. There again, the data's weak, but the kids who have high levels of arousal have a lot of anxiety, stress. There is kind of anecdotal, mostly clinical judgment, but there seems to be some benefit with SSRIs for those kids. But it's again, the jury's really definitely out at this point.
Are there any studies with substance-exposed infants or kids with neonatal abstinence syndrome?
All that I don't know specifically anger. I mean, what the primary findings and others in the audience could probably answer this as better than I could. Concentration, impulsivity are often common problems for substance abuse exposed kids, and of course that correlates with kids who have problems with anger. So there may be a relationship there.
And completely off the wall question. What about using service dogs to help kids read situations? Especially kids with autism, maybe.
That's a good question.
I'd like to thank you for an absolutely tremendous talk.
Thank you.
I have a question, but it's perhaps more of a musing than a question. So cognitive behavioral therapy is kind of like great parenting, great relationships. You're telling truth and love and collegially instructing.
Yes.
Back at the ranch, we live in a society that is about as far away from cognitive behavioral therapy as you could ever be. We're confrontational and somewhat negative. What are your thoughts on how we raise our children in a world that's so combative, such as our current presidential, say?
Yeah. Talking about bad modeling. Oh my goodness, it's horrendous. I think there's several problems in society today. One is just a lack of contact with parent and child. And even I hear story after story of even when we're at home, we're in separate places. They're on the internet. I'm on my game cube, whatever. And so they're not engaging. So how is the child going to learn how to read and how to emotional reading? How are they going to learn to negotiate through conflict if they're not actually engaged with each other? I think that's a serious problem, and the parents need to learn how important this is to manage children. And yes, I think so many things in life we learn through modeling. So many things. You can teach a child what they're supposed to do, but when they see you do differently. And by the way, when I get a referral for a child who has anger problem, one of my second order of business after I understand their anger is to go, okay, anyone else in the family has trouble with this? Because I've got to deal with that directly, otherwise the child will not learn. We're out of time.
Yeah, we're right at 9 o'clock, so any other questions we'll take at the podium.
Just an impromptu thing. Dr. Mabe is hosting a seminar just down the hall at Bingham from 10:30 to 11:30 around some of these clinical issues. So if someone could break free or had an hour, 10:30, you're welcome.